My name is Sam Wilson, and I'm a Golden Key Senior Service Coordinator with a specialism in personality disorders. We've developed this map in conversation with services across Bristol. This map is intended to visually illustrate multiple perspectives of the gaps between primary and secondary mental health services for people who have a personality disorder diagnosis or related presentation, or a history of complex trauma. The aspiration is to provide insight and understanding, enabling the gaps to be more clearly defined and to help identify thresholds, barriers, and good practice. I'll start by looking at issues in each area which might be creating the gap. Beginning at the bottom, primary mental health services like IAPT, which stands for Integrated Access to Psychological Therapies, may not feel able to hold the level of risk involved with a client with complex needs. And if a client appears to be chaotic and perceived as unable to engage with support sessions, they may not be offered the service. If an offer of support is made, it may not be appropriate for someone who may need more long-term therapy. People reported that secondary providers have sometimes used services like IAPT as a discharge option when it is not always the right fit, but there's nowhere else appropriate to refer the client to. People also talked about an inconsistency in responses to referrals, which can create a lack of clarity for both referrers and clients. Moving to the top of the map, and the barriers to accessing secondary mental health services. Often, personality disorders are not perceived as a serious mental illness. Also, the client may not meet the threshold for secondary support if their risk is assessed as not high enough. This client group can find engagement and sustained service use challenging, and secondary providers may not be able to offer a service or could discharge clients who cannot engage within certain boundaries. It was felt by some that there is sometimes a lack of clear criteria for accessing secondary services. Also, stretched capacity across services means there's a struggle to meet demand. So some people cannot access either primary or secondary provision and end up in the middle band of this map. The people who fall into this gap still need support and often turn to trauma services or emergency response for help. We'll look at the issues with accessing trauma services first. Some are similar barriers to that of primary and secondary providers regarding the ability of the client to engage or service capacity. Cost is also a problem as clients sometimes need to pay. If someone is accepted into the service, the benefits of a trauma therapy can be reduced without additional support in other areas of a client's life. Where people have little other support, they may engage more frequently with emergency response services. This provision is reactive, and cross-sector collaboration is challenging when it's not clear who else is supporting the client. This lack of continuity can lead to a client's repeated use of emergency services at a huge cost to the system. So, what is working well or might help in each area? In primary services, various things have been trialled. One example is the use of extended assessments over more than one session, which can help to deepen the understanding of a client's experience. In secondary services, taking a bespoke approach to signposting has helped to ensure a service is appropriate for the client's needs, and carrying out escorted referrals can help make transitions smoother. Trauma services can offer more flexible approaches, such as two-part assessments, online helplines, and regular waiting list check-ins. A pilot has been run to facilitate extended formulations for those frequently attending A&E. This has helped to improve engagement and to identify appropriate and planned support options. Despite all these things, people can still end up left in the gap without any support. Often people who have emotional dysregulation, instability, and who find it difficult to engage with and hold a distrust of services. So what do we need? In the centre of the map are some ideas which have emerged. Firstly, a preventative approach. Someone to work alongside a client and think about crisis planning to reduce interactions with emergency services. Secondly, assertive engagement. An individualised approach to think about how to engage a client. This might mean taking support to them and being persistent. This requires creative thinking and a person-centred approach. And then, the development of a trusted relationship with someone who can support a client to stabilise both emotionally and practically so they can access services. Furthermore, we also know that cross-sector multidisciplinary team approaches that offer wraparound support can be effective for some of the most complex cases. And lastly, appropriate therapy provision. It is possible to provide therapy to this client group, but it may need a slightly different approach. The reasons people end up falling into gaps are complex and systemic, and by working collaboratively, we can develop ways to better support people into appropriate services. If you would like to get in touch with us about this area of our learning, please email learningteam@goldenkeybristol.org.uk.